Hi, good afternoon, everyone, and welcome to the FUSE Early Life and Adolescence Cluster Lunch and Learn seminar series. I'm Cassie Muir, a Research Associate at Newcastle University and a member of ELAC's Leadership Committee. Myself and Hayley is also on the call, support the organisation and running of these lunchtime sessions. For a bit of housekeeping before we get started, if you could please have your microphones muted for the time being and during the talks, that would be great. There will be opportunity to ask questions at the end, so feel free to put your questions in the chat as we go, or you can come off mute later on and ask your questions to the speakers. We are recording today's session, which will be made available on the FUSE website as soon as possible. If you'd like to post about the event on social media, you can use the hashtag FuseELAC. And it's my pleasure today to welcome both Dr. Anna Basu, who is a clinical senior lecturer at Newcastle University and an honorary consultant paediatric neurologist at the Great North Children's Hospital, and Ange Broadbridge, who is head of implementation at Ways to Wellness. They'll be sharing with you today the SPACE programme pilot, which is a family-centred, hospital-initiated social prescribing service. So I'm really excited to hear what you've both got to say, and I'll hand over to you now to go through your slides. Thank you.
Hello, thank you very much for inviting us to speak today and for the introduction. Just to say that we were going to be three presenters, but our colleague Lauren, who is the team lead for the project, is not well today, so we'll speak on her behalf as well. So we want to tell you about our social prescribing project, and I'm just going to advance the slide, hopefully. Yeah, so this is the structure of the talk today. So going to talk a little bit about what social prescribing is, how it can help children with complex needs, why a family-centred approach is needed for this group, why we're doing this starting from the hospital, and then some specifics about the service and the huge advantages actually of delivering it through the voluntary sector, the VCSE sector, a bit about what we found so far in terms of evidence, benefit, and the social return on investment analysis, and then hopefully have a bit of discussion afterwards and have your thoughts and feedback, which we're very much looking forward to. So what is social prescribing? So I don't take this as a given anymore that everybody understands, but maybe you all do. But it's a confusing term because it sounds like lots of things and it isn't. So this is a definition that was produced through a consensus process quite recently. So it's a means for trusted individuals in clinical community settings to identify that a person has non-medical health-related social needs, and then to connect them to non-clinical supports and services within the community by co-producing a social prescription. I'm going to put that in verbal inverted commas, a non-medical prescription to improve health and well-being and to strengthen community connections. So in terms of what that looks like, you'll hear more about that in the talk, because I think sometimes it's the real examples that make it more clear what it actually is. There's been a lot of work looking at the benefits of social prescribing for adults, and there are various reports summarising this and reviews. But it can engage hard to reach patients, proactively identify and support them, and often there are times, again, we'll come back to this during the talk, but there are times when people do need more support with connecting to services and don't have the headspace to manage all of this on their own. It does empower people to engage and manage their own health, and this has sometimes been described as an improvement in patient activation. There's evidence for benefits to physical and mental well-being, reduction in GP visits due to anxiety and depression, and improvements in self-management of chronic disease and so on. So there are lots of benefits in that respect. There is evidence about reduction in NHS costs, and also it has a prevention role. And this is also really important. It does speak to the government's 3 shifts: sickness prevention, and the neighbourhood plans in terms of focusing on communities and the need for efficiency savings. So it has lots of value. It is something that is increasingly being used to support children and young people. Initially, it was very much young people and very much not younger children. There are schemes, and there is now, you've got the social prescribing youth network and so on. There is an increasing amount of social prescribing support for children, but the evidence base is still lagging, and access to social prescribing schemes for children is still, I think, a lot more patchy overall. But there is evidence of benefit in terms of well-being, reduced loneliness, and also these schemes do show a social return on investment, which is really favourable. Where the schemes haven't really generally gone yet is to support children with complex medical needs, and yet this is a group where actually there's a lot of obvious potential merit, because you've got children who have high medical need, and we know from the literature, there's a lot of data about this, that is often associated with high unmet social needs for the child and the family. We also know that this population of children accrue a lot of the child healthcare costs. If you look at the hospitalised child populations, there's the top 5% of that in terms of medical complexity accrue about 50% of all of the healthcare costs for children. So we do need to think about how we support the non-medical needs for the benefit of the children and their families, for prevention, and probably also because it's probably a more cost-efficient way of running services. Why do we need to be family-centred? I mean, this is kind of really obvious, because children don't present to healthcare services by themselves if they're young and they've got significant chronic health needs. And also their families are impacted by they have to do a lot of things. They have to look after their child, and they have to figure out how they're going to manage financially and so on. And there's an emotional toll sometimes to looking after a child with additional needs. And so we have to think about the benefit for the well-being of the whole family. That's about the smallest unit that we can think about when we're thinking about the needs of a child with complex needs. Families, and also if you have a child who has been hospitalised for the first time with a new life-changing disability, it's an incredibly overwhelming situation, and it's essential that we support families through this, because it's not a given that people are just going to take all of this in their stride and deal with all of the issues on their own for the first time. So we need to start this from within the hospital. We do need to have good community services, and I know there's a big focus on the 10-year plan with sorting out community and shifting focus away from hospitals. But a hospital is where someone is going to end up if you've never had a medical problem and then you get run over by a bus, or you have a brain inflammatory condition, you're going to end up in hospital. You're going to go to PICU or whatever, and then you're going to go down to the ward, and the child and family are going to have to figure out how to deal with a very challenging set of circumstances for the first time. And waiting until you're back in the community to start this process is just not a good idea. It's going to cause delay, and it's not going to be supporting people at a time when they really do need a lot of help. And also, the children with chronic complex needs are going to keep coming back to the hospital, because that is where a lot of their care has to be managed. I'm not against trying to support more things in the community, but we still need this kind of support in hospital, because there's a high concentration of unmet non-medical need inside that kind of institution. we've got to have it in the hospital, and it's got to then link to the community so that we can support people right from as soon as we know that there are needs that are not being met, and then link them up to community services and follow them up and embed them in community services, and at that point plan to move on. So that's the kind of role that this kind of service can take. And this is just this slide is a kind of summary based on having done a lot of interviewing. We've done some very formal analysis of our quantitative interviews, but this is a bit of an overview of the kind of situation that we're dealing with. Imagine a family is leaving hospital for the first time with a child who's acquired life-changing disability after an illness or injury, or a neonate, a newborn with complex congenital or genetic disorder. Sometimes a family might have to get their house adapted, move to a new adapted house in a new area. A child might have to go to a special school. The family struggling to process everything. There's anxiety, depression, stigma. Sometimes some people will walk away, and sometimes the siblings act out because they are not coping with the situation. Families very quickly spend a lot of money trying to manage when they've got a child in hospital, so it's very expensive, trying to get to pay for parking and transport and food. Sometimes the one parent might have to think about cutting their hours or giving up their job because of carer duties and appointments. How do you get to appointments? You've got maybe have a child who's in a wheelchair. How are you going to do the transport? How are you going to look after your child? Can you do those nursing tasks? And people are anxious about all of that, sometimes feeding. And how do you process what's just happened? And there's all of this which is put on a family, as well as just, getting on with all the medical stuff. This is huge. And I see it all the time because I'm a child neurologist. This is not an incredibly uncommon situation. So what I did, because I kept seeing this kind of situation, and it's not to say that a hospital wasn't trying to put some things in place, it's just that it takes quite a lot of resource to deal with this. And so we set up service after a lot of consultation with the public and with hospital management, and then also with Ways to Wellness, and we got some funding from the charity in the hospital to set up a service which we've called the SPACE pilot, which almost works as an acronym for Social Prescribing and Community Resources for children and young people with chronic complex needs. So it supports this group of children with chronic complex conditions and their families to be supported by a link worker, starting from within the hospital, but then supporting them beyond hospital discharge into the community for 6 months. And actually, practically, this is now turning into more like 9 months or even a little bit longer, because it's taking that long to really get people embedded into new support. So we started August 2022, phase 1, and we supported 49 families, but remember that's the child and parents or siblings. We started with children with neurodisability, because I'm a child neurologist, and that's I felt that was something that I could probably figure out how to do. Supported them with a wide range of goals, and we can come on. We'll discuss what those were. And we did some very, very in-depth data analysis for a relatively small group of families, just 18 families, but we collected enormous amounts of data about the goals and the costs and what was done. And so we were able to do a social return on investment analysis for that group. And we showed that you put £1 into the service, and essentially, and this includes the sort of setup cost for the service and so on, and you get £2.75 pence worth of social value back out, and there's a link there to the paper where we've described the initial evaluation. Then we had some extension funding, so because what we were finding was that other groups within the hospital were saying, well, we need this for our patients too. So it's not just children with neurodisability where you see these problems, rheumatology, immunology, bone marrow transplant unit. We'd like to be offering the same thing to these groups. So we expanded our inclusion criteria to cover children with chronic complex needs and also day case attenders. And we also So for children and families where, because the Great North Children's Hospital obviously has a large catchment area, so there are obviously people living in Newcastle, Gateshead, North Tyneside area coming in, but there are also people coming in from, Whitehaven, Scotland, anywhere in the country, and so it's unrealistic for link workers to have a hugely fine knowledge of that extensive area, but that we introduced a brief intervention category of support as well, so that we can support those groups. We're now on to phase 3, where we've got external funding from the NHS Charities Together Innovation Fund and the Legal and General Health Equity Fund, as well as ongoing financial support from Ways to Wellness. And we've extended our age criteria up to just under 18 years for this. So we're funded until the end of March 2028, so which is great, because we are continuing to capture data to show how the service works and show the benefits, because the long-term aim is to get this commissioned. So I'm really proud of what we've achieved, and so we have had competitive national funding. We have published our initial analysis, including the social return on investment, and that was highlighted in the NIHR annual report under inclusion. We've had national media coverage. We've been picked up as a case study for the National Academy of Social Prescribing, and we even got shortlisted for the best overall contribution to public health in the North East. So there you go. We've done some things, but we're not finished yet. And so we're talking to Sheffield and Alder Hey Children's Hospitals, who have set up some similar services since. And so we're looking to do an evaluation across these sites. And we've got interest and support from the Children's Hospitals Alliance. So that gives me confidence that we'll be able to take the next step and do a further sort of research into what works well and how, and what can we improve with these services and how much do they cost. So I'm going to hand over to Ange, because she's going to tell you about Ways to Wellness and what the amazing things that they're doing in this service and beyond.
Oh, thanks, Anna. I think I'm going to start by saying that what we're describing really is a unique partnership in terms of both delivery and evaluation coming together across hospital, community and BCSE and academia. I'm going to talk a little bit about Ways to Wellness and the role that we've played in the setup, I guess, and the delivery of this SPACE project. So Ways to Wellness are a charitable foundation. Our strapline is tackling health inequalities together. And I guess really we've become a trusted test bed for health inequality innovations across North East and North Cumbria. We innovate, we develop and evaluate models for transformation and sustainable change. And our mission is a health system that reduces health inequalities. We want to see people being really active participants in their own health and well-being, and really valuing the strength of all sectors. And as I say, this is truly a partnership approach, but we really want to highlight the value of the voluntary sector. The benefits of social prescribing for adults, as Anna said, are really well known, and we've been doing this work together to look at the benefits of social prescribing for children and young people. Ways to Wellness's work around this started back in 2015 in terms of building an evidence base around our long-term conditions social prescribing project. So we saw significant results there in terms of benefits to people managing their health, benefits around more social connectivity, some significant reductions in associated NHS costs, particularly results around diabetes, particularly results around antidepressant prescribing, and reduction in GP appointments too. And we've taken what we've learned through delivery of the long-term conditions project into projects like the SPACE Children and Young People's Project, in our work around maternal mental health, which we've shared a bit through some of the Fuse blogs and some of the Fuse connected channels over the last couple of years. We've been delivering work around perioperative, which started around hip and knee operations and now really looks at helping people to wait well for all operations. Work around persistent physical symptoms, and more recently some work with NECA Trailblazer around support to help people to move towards employment. So I guess we've taken what we've learned about social prescribing for a very specific group, adults across Newcastle with long-term conditions, and are looking at the value and the benefits of social prescribing across other user groups and needs. Next slide, please, Anna.
Oh, yeah.
Thank you. I forgot that I couldn't move them on there and I was just clicking a button. The benefits of joint working with the VCSE, I know for a FUSE audience, you know this stuff, I'm preaching to the converted here. So I thought I'd talk a little bit about what Ways to Wellness did in terms of delivery of the SPACE pilot. So our support in the initial phase was around recruiting staff. We have 3 staff on this project, Lauren, who's the team lead, who couldn't join us today, and specialist link workers, Fliss and Vicky. They work as Ways to Wellness employees, but with honorary contracts with Great North Children's Hospital. And that takes some time to set up and to kind of get that approach right. So in the early stages of this delivery, a lot of that work was around setting up those honorary contracts and making that work really well. We do a lot of work around making community connections. We've got a couple of really nice live examples of that at the moment. I think our brilliant head of comms, Jewel, might be on this call, and she may be able to share some links in the chat to some of these more recent developments. I guess one of the things that link workers do really well is work to identify gaps and opportunities in terms of community provision. So over the last few months, we've been working on a project, Your Move, with Northumberland Football Association, bringing together link workers, physiotherapy and coaches to support children around football who would otherwise not have an opportunity to play sport. So really accessible community opportunities. And it's really brilliant that we have such a fantastic team of link workers that can spot these opportunities and then have the flexibility within their roles to make new things happen, to get new groups off the ground. We also have a relatively new project, which we've called Space Owls, which runs out of the Owl Tree Cafe in the centre of Newcastle and is support for parents of under 5s, bringing them together for that opportunity for some peer support. And I can see, thanks very much, Jewel, for sharing some of these links in the chat there. Furthermore, support around developing partnership agreements to help this work to happen really well, to make sure that we've got the right governance around the work and the right safeguarding in place, and creating promotional materials too. And I can see we've got a couple of links throughout these slides. We will make sure that people have opportunity to access the slides as well as the recording, just so you can click through some of those links. Next slide, please.
Oh, sorry.
Anna.
Sorry.
I think as Anna really highlighted, people like Anna, many people in the region have innovative ideas that can make a huge difference to the lives of people in our region and beyond. And the knowledge and skills and community connections of the VCSE can really transform how health and care services benefit people that need them the most. And, you know, I know everyone on this call already knows this, the things that the VCSE can really uniquely offer are time, community knowledge. We have flexibility, you know, we're not constrained by some of the same constraints that statutory agencies face in terms of the way that we operate, and we can deliver experience of working with really diverse communities, so we can take these ideas and make them happen in the community and really robustly test their potential. And we also have great experience of testing new pathways, and that experience of testing new pathways continues to grow. So going back to phase 1 of the pilot, our eligibility criteria for the first phase was children and people aged under 16 who were hospital inpatients with complex chronic needs related to neurodisability. We worked at that point with families living in Newcastle, Gateshead and North Tyneside. And crucially, we worked with families with children who are not too medically unwell for current social prescribing input. And I think that's one of the real key learnings around social prescribing. You know, we work with people at the point that they're able to engage, or at the point where they're able to set some goals, because that's the real value of the work, being able to, you know, get together quickly, develop some opportunities to look at goals together and hopefully get things moving so there feels like there's a bit of momentum. And as Anna said earlier, when we look at some of our figures and the numbers of people that we've worked with, yes, we work with children and young people, but actually with any family, we'll also work with parents, with carers, with siblings, with grandparents. So we may work with one child within that family, but actually we've worked out that we've worked with, in some families, with upwards of 9 people within that little family unit. Next slide, please. So this is a really neat diagram just describing what the pathway looks like. So a referral will come in to the team, the link worker will meet with the family, we conduct a really holistic needs assessment, and I think we'll say a little bit more about exactly what those tools are a bit later in this talk. The link worker and the family will then work together to co-create goals to address unmet needs. And that's where we're really hearing about those gaps, you know, around the football, for example, that children and young people have things that they want to do, they really want to get involved in, or goals that the family perhaps have, say, around housing. And we'll be hearing about those things at this point. The link worker will then research potential solutions, will relay those findings and offers and often make direct connections to resources, but also go with families to activities, sometimes for the first time, or if a family needs a bit of support to build their confidence to go to activities, we might go several times with them. So not just that. I think sometimes around social prescribing, people think that it's about signposting. Often it's about going through the door and being a buffer against what is often a really complex system. So going to things with people, there's huge value in that. And then we'll have a period of follow-up. And this looks really neat. It looks like it happens hospital to community over 6 months, and it does on average, but we have some families that we've worked with for, you know, much, much longer than that. So a very flexible approach. And again, that's the real value of what the VCSE can do. You know, we're not constrained to we'll work with you for 6 sessions or we'll work with you for 3 months. We can support people into the much longer term. I think this one's back to you, Anna.
Oh, okay. So this is really just to show, so this was an analysis from the phase 1 study. So this is looking at children with neurodisability, and the slides come out a little bit cramped at the bottom, so you can't see all the full labels in full, but never mind. So it's really just to show the domains of support. So they used a tool called the support star, and our link workers use this to sort of map out the domains that they're going to make sure that they cover with families, just to think about, you know, have we captured things where the areas of need are? So it works in 2 ways. So one is that, you know, people sort of say where they are on a scale, or decide with the link worker where they are on a scale of 1 to 5 in terms of these domains. So, you know, money, friends, home and family, emotional issues, and so on. And then, but it's more about, well, why is this a 2? What would make it a 3? What is the actual issue that is going on here? And then, because then that helps to think about what would be a goal. And our link workers have helped a lot of families now. So it's a case of, well, from our experience, other families have found this resource really useful, you know, and they can talk about it, they know it. So they're like a living embodiment of information, but they also have records of resources, but they bring that to life. So we measure, so as a result of this, we do have some kind of metric of, you know, where have the goals been set, and where have they been met and led to an improvement. And the support star is sensitive to change, and we have seen significant reduction in unmet need through using this. And we also keep extremely, I mean, there is extremely detailed information on what goals were achieved, how, and how much things have helped. So we've got really good data. So we can show that the link workers are doing effective things and supporting families. And just to give you an idea of an example, so we do have you know, children who have spent very long periods of time in hospital, and this is a mother who has had twins born prematurely, and they basically spent the first 18 months of these twins' life in hospital. And so that meant, you know, not going to the local parent group, not connecting with your community support, and with the best one in the world, it is a bit grim being in hospital for that length of time. And so at the end of that, it was a bit like, well, how do I where do I go with this? I've got 2 children who have additional needs. How do I connect up to the community? And so actually this mother needed some additional support to feel able to go and join some groups, and was supported to find groups that were suitable for her, for where she was at and what she felt comfortable doing, which was to join a group with other children with additional needs. And she said she wouldn't have been able to go without having had that kind of link worker encouragement support, attending the first visit with them. And there's also been financial support. The family really did feel that they were listened to. They felt that the link workers were able to solve problems that other people hadn't heard or didn't really know how to help with, even if they were sympathetic to the issue. And there's a quote there which I won't read to you, but below the photograph that is taken from the because this is a testimonial from the Ways to Wellness website as well. But you know, it's clear that this family really felt that they were getting something from this service that wasn't otherwise happening, and it made a big difference to them. So just to say, so we have so you can actually see there is the full little video clip on the Ways to Wellness website, so you can actually hear this and some of the other stories from the perspective of parents and link workers and staff about the service. And there's also a link to the published paper. I say that we have undertaken a detailed social return on investment analysis, and the details of that are in the published paper. I think it's fair to say that we still so we calculated, you know, how much the entire service cost for the setup and the delivery. We have looked at the social value generated. I feel there's still some additional work to be done to capture some more financial information from an NHS perspective, because I think that is something that commissioners are kind of wanting, and so we are looking at that, and we're pretty sure it's there already, and we have some case studies that are very suggestive of that, and I'll come on to one of those shortly. So phase 2, so we expanded the service, covering children with chronic complex needs, day case attenders. We've had fairly sort of similar capacity to support, and essentially we have found that we are now supporting children from different parts of the hospital. It's still predominantly neurodisability, and I think that speaks partly to the fact that neurodisability is very prevalent in children with chronic complex needs, but also perhaps there's still a little bit of referral bias because of where we started out. So we're trying to continue to promote the service and make sure that people are aware of us and use the service well. But having new patient groups has meant finding new needs, and the team has worked well to adapt to addressing those, and some of the same issues come up again, but there are new things that are coming up. I'll give you an example of that shortly. But we are addressing a group that are often suffering from quite a lot of disadvantage in terms of poverty. There are issues to do with not being a native language English language speaker. There are families where they have no recourse to public funds, and so it's difficult for other services to necessarily find ways to support the families. And our link workers are very creative at finding solutions to help people, and it's really impressive what they've done. So just this is one example from phase 2. So this is a child who'd had a bone marrow transplant, and so the family have some challenges in terms of health in the wider health issues in the wider family. English isn't the first language, living in private rented accommodation with a significant problem with damp and mold. And of course, if you've had a bone marrow transplant, you're immunosuppressed, you can't go home to a house full of damp black mold, because you know the next thing is you'll be catching a fungal infection and be at extremely high risk. So you know, in this situation, sometimes the child just can't go home until the problem is fixed. The problem is it takes money to get a deep clean done to get rid of the black mold, and there wasn't the problem was the money wasn't forthcoming from any agency, and it took the Space pilot team were able to to do a visit, have a look, along with the sort of environmental health team, assess the problem, figure out what was needed, figure out how to get the funds, which was literally £150, to get the house to be in a suitable situation for the child to go home, and do some other things on top of that as well, but that was the main thing. And so we're looking at these cases in more detail from the bone marrow transplant unit, because there are cases where children are stuck in hospital for months because of this exact issue, and it's very clear that very quickly, we're saving a lot of bed days, and also the costs associated with being stuck in hospital. So NHS efficiencies as well as quality of life are being addressed through this service. So I feel very hopeful that an economic analysis would be in the favour of funding this service. We just need to finish doing one. So we're now on to phase 3, which we started in April. We are very thankful to a number of organisations, the NHS Charities Together Health Innovation Fund, and the Legal and General Health Equity Fund, and the Newcastle Hospitals Charity is kind of holding those funds and supporting. And I say there's still support from Ways to Wellness financially as well as practically in there. We are going up until, as I say, end of March 2028. We've expanded the age range. We're supporting a number of families. We're collecting the child's voice through some work with a psychology graduate. We're working with the new family hub structure in the hospital, and we're looking to collaborate across other trusts where these kinds of services are emerging, to collect more substantial data across site to really start to build up the case for this being a service that's available more widely, because we really strongly believe that all children's hospitals should be able to offer this kind of holistic support for children with complex chronic needs and their families. It's really something that they value, and we believe that for the child and family, but also actually for the hospital service, to help out staff who otherwise wouldn't know how to be dealing with these situations, and support with staff who do. This should be the way forward. So in short, we'd love to get commissioned, but it's getting from here to there. We're on the way, but we'll see how it goes. Lots of people have been working with us and supporting us and advising us, and this is a list of hopefully all of them, but there may be others that I've forgotten. But just to say thank you to everybody who's helping us with this, and thank you for your time. And we'd love to have your thoughts, feedback, and ideas. So thank you.